All right, my friends, let's go and get started. I'm going to introduce myself. I think most of you already know me. For those of you who have the good fortune of not knowing me yet, then I guess your luck runs out now. So my name is Jim Owens. I'm one of the child neurologists over at Children's, part of the Epilepsy group, and super pleased and happy to be the program director for child neurology over there. So when Claire asked me to do this, she made it very clear to me that this was not grand rounds. Like she could hear the fear in my voice that had given grand rounds, with Bruce Ransom sitting right there, fixing to ask me the question that I would then have to struggle to come up with the answer with so that he wouldn't regret hiring me, which I'm sure he often does, right? He's probably watching somewhere, isn't he? I don't want to know, okay? So not officially grand rounds, great. Informal gathering of friends, right? No problem. But that title, new, really kind of scared me a little bit because I'm always the last person to know anything. Right? I was the last person to know that it's the golden age of neurology. For example, it is the golden age of neurology. Right? So we decided to change the title of it. So it's 5 big things. 5 big things. But that also made me a little nervous. I'm a nervous kind of guy because what's big to one person, not big to another, right? That's a lot of pressure. Child neurology, it's a big area. Right? I mean, all my colleagues probably disagreed with what I chose and probably will, and that's why Rusty's here to heckle me, no problem, right? So we decided we'd modify it to this: 5 things big or new enough to capture my limited attention span, which I think should be the title for the whole series, right? And maybe one more modification. Since this is the first time child neurology has actually been a part of the 5 new things series, new, I'm going to define as since I finished residency, which was a while ago, as you'll see. Good. All right, so I'm comfortable, are you comfortable? We're all comfortable moving forward. Good. So I'm an epilepsy person, so I thought, no problem, this is easy. How many new seizure medicines have come out since I finished residency? Like 20, so no problem. I'll just talk about 5 of those, right? So how about these? I had a great little title for this, right? This was something old, something new, something borrowed, something blue. And if you don't get the epilepsy joke, that means that you're psychologically normal, but just to explain it, right, so esophageal fatigue is associated with blue discoloration of the skin. There you go. I was ready. And you might say, well, what would you do for number 5? And I said, well, you can't do an epilepsy talk without cannabidiol. But I don't want to talk about cannabidiol ever again. I talk about it every day in clinic. So I thought what I would do, not prescribing it to whoever's listening, right? So I thought that what I would talk about is a case, right? A story. I'll tell you a story of a patient, maybe an amalgamation for didactic purposes of patients that I've seen in the past. And think about how things might have changed based on some things that have happened over the last, 4 or 5 years, right? So this is a fairly typical story. Patients we see, uncomplicated pregnancy, things seem to be going fine. Atrial nuclear ultrasound, possible ventriculomegaly, but we'll just watch. And they did. Triple screen was normal, so no neural tube defects, that sort of thing. Born at 38 weeks, appropriate for gestational age in terms of weight. APGARs were concerning, obviously 3, 5, and 5, not doing well. Got positive pressure ventilation for 48 hours, ventinasal CPAP. EEG, which is of course a vital test for the newborn, showed a moderate degree of encephalopathy, so some scattered sharps, a little bit of excessive voltage attenuation during sleep states, right? Patient had a flurry of kind of multifocal clonic seizures. Weren't captured on EEG, but they were clinical, so they were treated with phenobarbital, of course. Resolved clinically by 5 days, and the patient went home on phenobarbital and was soon weaned off. Then, unfortunately, at 5 months, the patient started having typical flexor infidel spasms, improved somewhat with ACTH, but didn't go away. Treated with zonisamide, which was a new thing way back then. And the seizures, the spasms resolved at 14 months. You could argue they would have anyway, right? And that's the joy of being a pediatric epileptologist, is that a lot of things go away and you can take credit for it, right? So I did, right? But unfortunately, as you might expect, given that there was another column to go, at 23 months, almost 2 years, the patient started having nocturnal tonic seizure. So axial stiffening, variable degrees of appendicular stiffening, and then developed atonic drop attacks, and then developed staring spells or dialectic seizures, if you want to be Cleveland Clinic about it. And those proved to be atypical absence, and so the patient has what sounds like Lennox-Gastaut. An EEG was performed, which showed consistent features, which we'll talk about in just a second, just to remind you. And so the patient was treated with the entire kitchen sink and the kitchen cabinet that we had at the time for the most part, right? So I started again on zonisamide because that seemed to work, right? That stopped the spasms. Put back on valproic acid, felbamate. Many people probably have not used felbamate. Used felbamate, ethosuximide, clonazepam. That is a nasty brew of cocktail of chemicals, right? So, for example, the felbamate will make the valproic acid level higher, right? There's all kinds of scary interactions there. But, you know, you're trying to stop these seizures, which are happening daily, multiple times per day. Developmentally, the kid, unfortunately, as almost all patients with Lennox-Gastaut, don't do well. He was not doing well. He was always delayed, never on track. Regressed with the spasms, started to pick back up again, and then just didn't go anywhere good after the Lennox-Gastaut really set in. So he was diagnosed with moderate mental retardation and pervasive developmental disorder not otherwise specified. Keep those terms in mind, given his cognitive and behavioral profile. And his evaluation, state of the art for the time, metabolic screen, which we still do, right? Serum amino acids, urine organic acids, lactate, those sorts of things. A karyotype with telomeric fish to make sure all the little telomeres were still there, and they were. And a 1.5 Tesla MRI was just fine. So cryptogenic, I guess, as you might say. So that's our patient.
Was this at your residency?
This was in my residency, and during a time, this was not at Seattle Children's. I'm not trying to imply that anything like this would happen at Seattle Children's nowadays, right? This was in Texas.
Okay.
So let's think about now, and is there anything we might do differently about this patient's treatment now? Lennox-Gastaut syndrome, as you all remember, is age-dependent, severe epileptic encephalopathy, severe both in terms of the frequency of seizures, the types of seizures. These patients have all kinds of injuries from their drop attacks, and also severe in terms of neurodevelopmental outcome. 95+% of these patients end up nowhere near normal development. Right? So it's a severe epileptic encephalopathy. Peak onset is in kind of the preschool years, almost always starts before the age of 8, although there's obviously exceptions, can start in adulthood in some severely impaired patients. And the hallmark of it is multiple seizure types, tonic, atonic, atypical absence, and then a host of other things. They can have myoclonic, they can have generalized tonic-clonic, as this patient did. The EEG features, as you remember, slow background, slow spike and slow wave, right? So 2.5 hertz, kind of usually frontally dominant, generalized, interictal, but very rhythmic, slow spike and slow wave. And then generalized paroxysmal fast during sleep. So that's the whole package. These patients, the epilepsy doesn't go away. So if prevalence equals incidence times duration, which I think it does, right? Then this represents a big chunk of the epilepsies we see in childhood because it doesn't go away. These patients stay in our clinic until they graduate to the adult clinic, right? So occupies a lot of epilepsy real estate. And it also probably occupies a lot more of our time than 10%, as is usually the case in neurology. 10% of the patients occupy 90% of your time. So medical therapy is approved now, FDA approved, and then also what's commonly used off-label. I will be discussing off-label use. I should have put that in disclaimer. I apologize. I'm now disclaiming to you all that I will discuss off-label usage of anticonvulsant medications. Okay, so what's FDA approved? So felbamate, talk briefly about some of these, but focus on the last two there. Felbamate, lamotrigine, topiramate, rufinamide, and clobazam. And then there's 3 that are commonly or have commonly been used off-label. There's a recent survey in epilepsy that suggested that the order people usually use these medications in is they start with valproic acid, because valproic acid treats everything, right? And then when that doesn't work, as it oftentimes doesn't entirely, they'll move on, they'll skip felbamate for reasons that you probably remember, and move on to lamotrigine for the synergy with valproic acid that was so well demonstrated by one of our own colleagues, right? And then topiramate is oftentimes third choice, sometimes zonisamide. That's changing, although we don't have another survey since clobazam came out, right? So a lot of people will start to use rufinamide early. Some people start to use rufinamide actually as the first-line agent. And clobazam is oftentimes used. And clobazam has largely replaced clonazepam for most people, for reasons we'll talk about in a second. It's really clobazam, I think, that is one of the big new things, at least to me in my very small world, right? And you might say to me, Jim, that's not very new, and you'd be right, but hey, it's my talk. So we're going to talk particularly about rufinamide and clobazam, just briefly. So refinamide, when you think about what it is, it's not a medication that you would immediately say, let's try that in Lennox-Gastaut. That sounds like a good idea, right? Because it's just another assault on the voltage-gated sodium channels, and it's not even a novel assault, really, on the voltage-gated sodium channel. It's not like lacosamide that does something different. Lacosamide stabilizes the slow inactivated state. That's different. That's new. And that's maybe one of the reasons why lacosamide may, again, off-label, work for more generalized epilepsies, right? It's not like phenytoin, carbamazepine, carbazepine, the way it works. Refinamide is a lot more like the kind of standard sodium channel agents, right? It stabilizes the inactive state. Remember, there's the depolarized state, there's the inactive state, and then there's the repolarized state of the voltage-gated sodium channel. And if you stabilize the channel in the inactive state, then it can't fire as much. So it's a use-dependent inhibition of sodium channel activity, right? And that's what refinamide does. Certainly can be useful for partial seizures. That's, of course, how all seizure medicines are tried at first, is add-on for partial epilepsy, and it certainly has efficacy for that. But it seems to have particular efficacy for Lennox-Gastaut. It has in trials, right? Its adverse effects are the ones that you would expect. So all seizure medicines cause you to be dizzy and drowsy. It may have a little bit excess dizziness compared to some other ones, not quite as much as lacosamide. Can cause some nausea and can cause QT shortening, which that's not a problem for most people, but you got to make sure the QT is okay before you start. So it's fairly easy to use. It comes as a suspension. It's easy to use in kids, and it's approved for kids age 4 and up with Lennox-Gastaut. And it's a cool structure. It's a triazole structure. You can see that kind of broken ring in the middle there. That used to be a ring, and then they substitute a fluorine in it. It's pretty cool. Okay, so that's refinamide. It was approved in 2008, really kind of has been increasing in usage over the subsequent years. What about clobazam? Well, clobazam is not really new, as you all know, right? First of all, it was synthesized in 1966, which was a great year. Lots of good things happened in the 60s that we don't want to talk about, right? But it wasn't FDA approved in the United States until 2011. It had been approved other places, certainly well before then. When it was first synthesized, it was synthesized as a different kind of benzodiazo ring, right? So diazepam had been synthesized and was becoming the blockbuster drug of the 60s, right? Mama's little helper, right? And everybody wanted the next diazepam, just like everybody wanted the next Viagra, right? So everybody wants the next blockbuster drug, so they decided, let's modify it. Let's make it a 1,5 benzodiazepine. What does that mean? So 1,5 refers to where the nitrogens are. So if you count the nitrogen, you go either way, but usually go what's closest to the particle bond here. So 1, 2, 3, 4, 5. So it's 1,5, right? I'll show you what diazepam looks like in a second. So it's a 1,5 benzodiazepine. Its half-life is fairly long, right, which is helpful in treating seizures. Clobazam's half-life is somewhere 36, 42 hours, maybe a little longer in some patients. One of the important things to know about it is that it has an active metabolite, desmethylclobazam. And desmethylclobazam is actually equally active to the parent compound, right? So it's not partly, it's equally active, and may actually be responsible for a lot of the therapeutic effect. Desmethylclobazam is broken down by, or it's metabolized, I should say, by 2C19. And it turns out that patients who have certain genetic polymorphisms of 2C19 are slow metabolizers of desmethylclobazam. And those patients tend to accumulate a lot of that metabolite, which labs can test for. They won't oftentimes routinely unless you ask for it. Slow metabolizers can have a lot of side effects as they accumulate this side effect, this bioactive compound. And the half-life can double from 70 to 80 hours to 120 hours or longer. So patients can get really high desmethylclobazam levels if they're slow metabolizers. The charm of clobazam, and the reason the FDA looked at it, is because it was reported and shown in studies to produce less sedation and less drooling, which were the main side effects of clonazepam. Clonazepam, every patient that you put on it and you get therapeutic on it starts to drool. I shouldn't say every, but a large percentage. All the patients would call you and tell you that the kid was drooling, right, and excessively sedated. And clobazam seemed to not do that to the same extent. First, I'm going to just show you quickly diazepam just to show you the difference. It doesn't seem like much of a difference, right? But there's 1, 2, 3, 4. So that's diazepam, called so because there's diazo, 2 azos, and a benzo. So diazepam, benzodiazepine, right? Always fun to know what I call things, what you call them. This is an X-ray crystallography structure of a GABA-A receptor. Not really, it's just a schema, right? Just to remind you that benzodiazepines bind between the obligate alpha subunit and the gamma subunit. And it may be that part of the reason why clobazam does not have the side effects that diazepam does is because it doesn't seem to bind to alpha subunits containing 1 and 4. Alpha 1 seems to be mostly associated with sedation, right? So if you bind preferentially to GABA receptors that don't include alpha 1, then you'll tend to have less sedation. And you can have benzodiazepines that produce no sedation, right? Ones that do not bind to the alpha 1 subunit, right? Clobazam does not bind to the tonic GABA receptors, the ones that handle extrasynaptic inhibition. So it doesn't seem to be the way it works. It is a different binding site, or at least a subtly different binding site than classic 1,4 benzodiazepines, although it's not exactly clear exactly where it binds. All right, so what do you choose, right? So the most recent, so there's been several Cochrane reviews, and they've essentially been identical. I think they probably Xeroxed them for the most part, which is optimum treatment remains uncertain. Why? Because there's no head-to-head trials, right, comparing these things. You can indirectly compare effect sizes using fancy statistics, and you can suggest that clobazam is probably more efficacious, particularly for drop seizures, right? And it turns out that we've got lots of things we can throw at drop seizures to make them go away. It's the other seizures that remain challenging, unfortunately. Right? Felbamate, lamotrigine, topiramate all certainly show efficacy, but nowhere near what clobazam does, particularly high-dose clobazam. Certainly non-pharmacologic things you can do. Ketogenic diet, vagus nerve stimulator have about the same responder rate as with other kinds of epilepsy. About 50% of patients will have a more than 50% reduction of seizures. Epilepsy surgery, there's lots of different things you can do depending on what the patient has. About 25% of patients with Lennox-Gastaut will have focal features, and so it's always reasonable to think, is there a resective option? And sometimes there is. And then palliative options like corpus callosotomy, I would say that's actually a new thing. It's not new, it's very old, but it's actually coming back. People are talking a lot about it. It seems like it's very effective for atonic drop attacks, right? As is vagus nerve stimulator. Corpus callosotomy overall is probably more effective for drop attacks, but families find it less palatable than the vagus nerve stimulator and certainly less palatable than clobazam, so you may start with clobazam first. Okay, so that's quotes, big thing, number 1. What about the kids' development? We talked about that. How would we characterize that now differently than what I did way back when in the dark ages? That brings up the idea of comorbidities of epilepsy. This is also not a new thing. This is something that epilepsy rediscovers every decade, right? So there was an NIH consensus panel in about 2000, 2001, where the whole thing, it was a 3-day thing. I went to, there were posters, everybody was very excited. We were going to focus on comorbidities, psychiatric comorbidities, behavioral comorbidities, not just the shaking, my friends. We were going to work on that, and nobody did. Because it's way easier to study rats that shake than rats that are depressed. And so everybody studies shaking, and we always forget comorbidities, but now we're coming back to that again. This actually just showed my email inbox today, World Brain Day. World Brain Day is next week. It's Wednesday. Rusty, I didn't get you anything for World Brain Day. I'm sorry. I didn't know what to get you, right? There's lots of comorbidities we have to take into account. Bone health, very important for us to take into account as child neurologists because a lot of our patients then graduate to being adults with epilepsy. They stay on these medicines for years and years and years and develop bone demineralization over time. In kids, particularly kids on the older seizure medicines, but also patients on the newer seizure medicines, as it turns out, they have lower levels of serum calcium, lower levels of phosphate. They may not have frank bone demineralization, but they clearly are at risk for it. Right? Vitamin D levels are low, so we're learning that we need to check those and supplement vitamin D, particularly in usually not so sunny Seattle. Sleep disturbances, we'll talk briefly about, as we'll talk about some of these other things that can make life miserable for patients with epilepsy. Sleep, important for everything, right? 20% of patients only have seizures at night, and that certainly will mess up your sleep cycle. About half of patients with epilepsy have sleep maintenance insomnia. They're really sleepy, they fall asleep quickly, but they wake up frequently. And when you do polysomnography, you see, yeah, they do wake up frequently. They have fragmented sleep, they have less N3, they have more N1, so more light sleep, less restorative sleep, and that's a problem. Obstructive sleep apnea, we've known for a long time. It's actually probably more a problem in kids than in adults in terms of patients with epilepsy. 20 to 30% of kids with epilepsy, all comers, have obstructive sleep apnea. If your obstructive sleep apnea is not treated, your seizures get worse. If you have bad epilepsy, your obstructive sleep apnea is worse. They interact in a way and make each other worse. So that's something that we're increasingly remembering to think about. So when seizures are bad, maybe we need to look at their tonsils instead of just their EEG. All the drugs, almost all the drugs we routinely use to treat seizures make sleep worse. They mess with it. Pregabalin actually may help a little bit. Again, that's off-label. Neurontin may help a little bit, small case series, but everything else makes it worse. Fragments it, decreases N3, increases light sleep, decreases REM, that sort of thing. Psychiatric comorbidities, we've known for a long time that patients with epilepsy, both kids and adults, have a significantly increased rate of depression, of unfortunate suicidality, of anxiety, right? Harder to detect in some ways in kids because kids, when they're depressed, don't necessarily look depressed. They can look hyper, they can look oppositional, they can just look like they're withdrawn. So there's a lot of different ways that pediatric depression can present, and so we need to be mindful of that. Behavior problems are also a significant problem. We hear a lot about that from our patients. One of the interesting things to think about is that behavior problems in kids with epilepsy may precede the onset of epilepsy in about 25% of kids. And what it just suggests or reminds us of is that these are brain development disorders that all travel together. It's all coming from the same substrate. It's not coming from the spleen, right? It's coming from the brain. These are all brain disorders. And cognitive dysfunction along the same lines. So almost half, say 40% of kids with epilepsy have some degree of cognitive dysfunction, enough to actually merit a neurocognitive diagnosis, including ADHD, which of course every kid in America now has, right? Kids with epilepsy do less well over time, less likely to graduate from college, from high school. That's even true for patients with what we would think of as the good epilepsies, if there is such a thing. It turns out there's not. So childhood absence epilepsy, it turns out to be true for patients whose seizures have gone away, right? So again, there's something wrong with the brain, and it's not just the seizures. The earlier the onset of epilepsy, obviously, the more other comorbidities you have, the more likely you are to have a bad outcome. And of course, as always, iatrogenic factors are key. Our anticonvulsants can make things worse. So just, for example, not-so-benign Rolandic epilepsy. And if you're going to choose an epilepsy to have, you would probably want to choose this one, but that would not be good because it's actually not so benign in terms of neurocognitive outcome, right? So the full-scale IQ is usually normal in patients with Beck's, although it may be somewhat left-shifted, kind of like it is in Duchenne's muscular dystrophy, normal but left-shifted. The early studies showed, or studies looking into this, first showed deficits in language processing. Subsequent studies showed some patients had problems with visuospatial function. Someone thought, well, that's probably related to which side the spikes are predominant on, and that's not true. That would have been a great story, but it's not true, right? And interestingly, as you know, benign Rolandic epilepsy, the seizures go away almost always by 18, almost always by 16, but these deficits seem to outlive the seizures. Right? So again, it's not just about the seizures, and we're remembering that. And we're also looking now at some of our benign epilepsy syndromes and realizing they're not so benign. Childhood absence, the same. Terminology is changing, right? Just so you know, the terms that I used way back when no longer apply. So, for example, pervasive developmental disorder, no Asperger's, right? I'm sorry, some of you may carry that diagnosis. So it's autistic spectrum disorder, right? So just one thing, one big umbrella, right? Just one term that incorporates all of that now. And the way it's diagnosed has changed a little bit. Some categories have been collapsed together, and sensory sensitivity is the restricted interest category. And I think also we change what we call developmental delay approximately every decade or so. With DSM-5 was changed again, right? So now it's actually intellectual disability, which sounds better. I agree. I like saying that better. Okay. What about the fact that the patient was born early and had such a rough start? Is there something we could have done then that we could do now that we couldn't do then? And the answer is maybe, right? Maybe. So therapeutic hypothermia for hypoxic ischemic encephalopathy is certainly not new, so it became standard of care in 2008. But it's increasingly being used and it's increasingly being refined, right? And we'll talk about kind of maybe the future ways that's going to unfold, hopefully, in the next couple of minutes. Original studies looked at head cooling versus whole body cooling. There didn't seem to be a lot of difference between it. Depended, however you got the baby cool, active or passive, It seemed to help outcomes, right? I would say, in a room full of adult neurologists, right, I would say about as well as TPA helps patients with stroke feel like they're never needed to treat, right? So about 7 number needed to treat for patients that had a severe encephalopathy, severe neonatal encephalopathy, about 6 with a moderate encephalopathy. Easier to help someone who has a moderate encephalopathy than someone with a severe encephalopathy in terms of preventing major disability or death. So helpful, certainly not a slam dunk. Criteria for cooling, this is for patients who are term, so 37 weeks or up. Right? At this point, although that's one of the active areas of interest, is what about the near-term patient? That's an area that's actively being investigated. To qualify, the patient has to actually have an encephalopathy, right? So this is hypoxic-ischemic encephalopathy, so you got to have the E of that, right? That can be documented by several events. Patients had loss of heart tones. Patients had an APGAR score at 10 minutes that's 5 or less. That's obviously criteria. You can also use this SARNet score, which is a big long table that includes things like how conscious is the baby, does the EEG show seizures, autonomic function, and so on. So you can use this to try and figure out, is the baby encephalopathic enough to warrant cooling? Like TPA, right, it has to be given within a certain amount of time or it's not effective. So it has to be started within 6 hours. The original trial was 5.5 hours. They rounded up and gave you 6 hours. My interest, because what keeps me up at night or wakes me up at night, is the question of continuous EEG, right? A lot of the original trials were done with amplitude integrated EEG, which you may not have seen or heard of. So this is putting 2 or 4 electrodes on the head, using that to come up with 1 to 2 channels of EEG, and then just looking at the amplitude of that compressed over time, right? So you look at a whole hour or more, 2 hours and half a day on a screen, and you're looking to see how the amplitude has changed. It turns out that's really helpful for looking at things like state change, background. Turns out it's not really a good seizure detector, though. One study showed that experienced neonatologists who had looked at lots of AEGs only caught about 20% or so of seizures that were documented by conventional EEG. So conventional EEG is better, right? So, which I shouldn't say so happily, because of course that means then I'm going to get woken up in the middle of the night to do that conventional EEG. CEG is the gold standard for detecting seizures in the neonate. There are automatic detection tools which are getting better, which is great, because they used to be really, really bad, right? They used to basically miss all the seizures and hit on all the artifacts, right? Not helpful, unless you're counting artifacts. They're getting much better, and that's great. So the question, as we do this more and more, so it's very labor intensive to cool infants, it's labor intensive to do continuous EEG. The overriding question is, does it matter? Does it matter in terms of outcome? And I would say that to a certain extent, that is still an open question. And that's a question everybody wants to know the answer to. I think we're coming to some answers. There's some obvious answers. So if the patient has focal status epilepticus, electrographic status epilepticus, they're seizing all the time, that's bad for outcome. And stopping that is helpful for the most part. If you have, 30 minutes an hour of seizure, well, then you're in status. What about 25 minutes? Well, that's still probably bad for your outcome. What about 2 focal seizures that last 30 seconds every hour? We all kind of go, well, probably not, but nobody really knows for sure. The best evidence we have so far is that if you have 20% or more of time during an hour occupied by seizure activity, that predicts a bad outcome. I would still say what we don't know for sure is if you stop those seizures, do you improve the outcome, or is that just a brain that's really been injured that's acting out? That's certainly possible. But we're moving towards thinking of a 20% cutoff as kind of a rough place to think about intervening aggressively if we have to. This slide, and the other 2 came from Nina Natarajan, our new neurologist, and she likes the cocktails and ice description of the oncoming therapeutic strategy. Cocktails and ice, so cooling the baby plus giving other neuroprotective strategies. Did you think I was going to talk about something else? Did you? It's almost Friday.
Do you shake or stir?
Shake and not stirred, of course, my friend. So there have been, I think at last count, 27 different neuroprotective trials. None of them have helped. Right? So NMDA receptor antagonists, all these things that help mice when you stick threads up into their middle cerebral artery and make them have strokes, and you treat them with MK801, gosh darn it, their stroke size is much smaller. But when you try it in humans, it just doesn't work. The side effects are horrible, or it just doesn't work. Turns out that rats are different than people, usually, right? That has not dissuaded people from trying, however. So there are ongoing trials in several things. Pyramate has long been talked about as a neuroprotective agent, partly because it has antagonist activity in both AMPA and NMDA, NMDA being one of the bad players in excitotoxicity. Xenon, which sounds fancy, xenon gas actually is an NMDA receptor antagonist, so that's another ongoing trial. Clonidine, not sure why someone came up with that idea, but they did, right, and that's currently undergoing trial. Melatonin, why not, right? Help babies sleep, man. I don't know, so melatonin is a free radical scavenger is the idea, erythropoietin, right, oxygen delivery. And so CBD at the very bottom in parentheses, because again, I don't want to talk about it, but people are starting to talk about it as something to give to babies. ROB told us that lots of pregnant women are now taking CBD because it's good for you, it's natural, like plutonium. Okay, so.
So do you,
Yep.
is there a one-line opinion about CBD for certain types of seizures, or is it
Yes.
that you,
So the one-line opinions on that. The one-line opinions we don't know. We actually don't know. The evidence so far is anecdotal. Nobody published a newspaper article when somebody became seizure-free on lacosamide, which they often do.
yeah, right.
But those
Studies are ongoing.
studies are ongoing, and there's reason to be hopeful. I think it's great. I mean, it's a different way to get a chemical into the brain. It's cool. Oh, cannabidiol. I'm so sorry. Cannabidiol, which is one of the non-psychoactive components of medical marijuana. I apologize. Right?
Dr. Krause only knows it as weed.
Okay, sorry. So it's like token weed, except you don't have to sit on your parents' couch and eat burritos, right? That part's gone. Not that I've ever heard of that. Okay, moving on. So what about testing? So the last couple things, and we're down to the last two, I promise, is what other kind of tests could you do to try and figure out what's going on? Okay. So this patient had an 18-week ultrasound, as pretty much every pregnant woman now does. Showed a little ventriculomegaly, but it was nonspecific, and so they didn't do anything. Right? Hannah knows what's coming next. You know, it's how you spend all your time. This gave Hannah a job. So I used to think that ultrasounds, and I still think that ultrasounds look like a snowman in a snowstorm. I mean, I just can't make it. I remember as a medical student looking at one and saying that looks like a normal brain. I was going to be a neurologist. I think I was on your service, Dr. Swanson. And someone pointed out that was actually the butt. May not be a huge difference, right? So ultrasounds have certainly gotten better. Now there's two-dimensional ultrasounds and three-dimensional ultrasounds, and they've gotten lots better. But still, nothing beats an MRI, am I right? I'm right. This is from our own UW Medicine, right? Go team, go Huskies. So fetal MRI is also not new. I'm not telling you how much new. It's just things that are kind of now surfacing as exciting things. So the first fetal MRI images were obtained in 1983 by people with very big hair, right? And Walkmans, right? Maybe Discmans. The MRIs back then basically looked like, probably CTs used to look like, which is one big gray blob, right? But they've gotten a lot better, as you can see. The nice thing about MRIs, it's not limited by all the soft tissue and other sorts of things that tend to get in the way of looking at the baby, right? When you got mama, right? And it's much better resolution in terms of like gyral pattern, sulcation, things like that, right? No harmful effects have been found up to 3T, right? I don't know if anybody's put a 7T put a woman in 7T yet, and I don't think anybody probably will anytime soon, but 3T certainly is possible. Generally performed after 17 weeks. Part of that is just because the baby's really small and moving around and flipping around a lot. It's kind of hard to acquire images. And also because usually MRI is done because the ultrasound looks abnormal, and the ultrasound is usually done around 17, 18, 19 weeks, right? Good to do an ultrasound first to get a sense of what you're looking at, gestational age, and so on. I want to know how they do this, right? I mean, we've all had patients who couldn't make it through the scanner, who are too squirmy, right? And I mean, if you've ever seen someone go through an obstetric ultrasound, it's like an acrobatic feat, right? I mean, you're chasing the baby, and then the baby's asleep, and you got to wake the baby up, and then it's flipping around. So it turns out the way you do it is you get 3 orthogonal images as your initial sequence. You figure out where the baby is. There's a coil that's sitting over mom's belly, right? And you got to center that over the skull, because that's, of course, what you're most concerned about is the baby's head. Who cares about imaging the heart and stuff like that, right? And then you got to quickly obtain your first sequence, right? Usually 3 to, if the baby's really moving around a lot, 5 millimeter images. And then you can reposition the coil based on how things look during that image sequence. And so you're basically using each sequence as the localizer for the next sequence, trying to keep baby in frame, as it were. And I guess it usually works. Sometimes works, right? If baby cooperates. If baby cooperates, you can get some really cool images, right? So on the left, you see a diagram of how neuronal migration is supposed to look. So in the middle, the red there, that's the ventricular zone where the cells are starting, and then they move out to the cortex, and you can see those regions quite well here in a fetal MRI, right? And you can also follow the development of gyration over time. This is just really pretty cool, you got to admit, right? So you start out with 16 weeks, 19 weeks, not really any bumps yet. Looks lissencephalic, but it's physiologic lissencephaly, I guess, right? 25 weeks, you start to see a little bit of formation of some gyri there, some opercularization, right? 30 weeks, you can see more bumps, and then 33 weeks, gyration is really coming full steam, right? So you can see gyration, you can see sulcation, you can look for abnormal patterns, you can see gray-white differentiation, right? So could you see a small focal cortical dysplasia? Probably not. But could you see a larger area of dysplasia? Probably so. Can you see larger malformations? Absolutely, right? So it's a little dark, I apologize, but if you look up here, you can see this is a malformed cortex, right? Malformed because there's no cleavage here, right? So, and there's this mass in the middle that's formed, right, in this sort of univentricle. So this is semi-lobar holoprosencephaly. Semi-lobar because there's a little indentation there, there's some sulcation starting there, semi-lobar holoprosencephaly. And then in the sagittal plane, you can see there's actually abnormality of the corpus callosum. So there's the corpus callosum, and conveniently where the white arrowhead is, it stops, right? So partial agenous corpus callosum. It's a 29-week infant. Down here, you can see even more profound agenous corpus callosum, complete absence of the corpus callosum. You can see absence of the singular gyrus, right, with these tangentially arrayed gyri, bundles of Proust, right? So you can see agenous corpus callosum. Again, this is a 29-week infant, right? So you can see malformations that you could maybe see evidence of in ultrasound, but in nowhere near the same detail that you can here. What might happen next? The next new things, when someone else does this and not me, right? What might they talk about? Probably something way more interesting. However, one thing they might talk about is fetal MEG and fetal fMRI. Which sounds just kind of Star Trek-y to me, right? So here's a MEG, right? Looks like a big hairdryer in the beauty salon, which clearly I need to visit, as you can tell, right? How would you do a MEG, right? Well, instead of having it come down like this, you have it oriented like this, and mommy puts her belly in there, right? And you can do a MEG. You need about 10,000 cells to make what one of the super quantum interfering devices picks up on the scalp surface. And it can pick up very small magnetic fields. You can use source localization to basically get rid of all of the other electrical activity. Baby sitting in the uterus is electrically active, right? And frequently electrically active for around 20 weeks, right? So you have to somehow be able to get rid of all that to source localize within the brain. But fortunately, that's not hard to do computationally because you know where things are supposed to be if you have a Ph.D. in that kind of stuff. Fetal MRI, you can do resting state MRI, right? If the baby will hold still long enough, you can actually put a seed and see what's connected to what at resting state. Baby's supposed to be resting in there. And you can also do task-based, right? You can do flash visual stimuli, right? Tied to fMRI acquisition. And you can do auditory stimuli, which is actually not as bad as it sounds. They use that all the time in labor and delivery to wake baby up, right? They put this thing on the belly that makes this loud sound if baby's not moving enough, right? And just do that and acquire images at the same time. There you go. New things. The last thing I'll talk about, yes, sir.
So well, if you find at 29 weeks, was it partial agenesis of the corpus callosum?
Yeah.
What do you tell mom? What do you do?
This is what Hannah does all the time.
Yeah, you and I can have a whole conversation.
Yeah. Yeah, it's a good question, right? And,
Mom, what she wants to do.
yeah,
What she's looking for. Often the ones who get MRIs are the ones who want as much information as possible.
right,
And the ones who don't really bother to get them are the ones who we're just going to go with it.
right,
So,
right. And some families want to know as much as possible to prepare.
Yep.
Some families want to know as much as possible to make decisions about the pregnancy. So, in terms of what we say about what the outcome will be, that's a good question, right? It depends on the amalgamation of all the different malformations that you see. If you see partial agenesis corpus callosum and everything else looks fine, somewhat uncommon, it'd be hard to say much about that. If you see semi-lobar holoprosencephaly, you have a pretty good idea of how that's going to go, right? How bad the developmental outcome will be. So, did I answer your question?
Yeah, I don't know what to do.
I don't think anybody does. I think that's outside the realm of neurology grand rounds.
Actually, following up on new technologies, is there any sort of fetal EEG that can be done?
Yeah, that's a great question. So one of the original fetal studies, right, were EEG, that they were kind of done during delivery, right? So you kind of put the electrodes on as baby's head became evident. The challenge with doing any kind of EEG from the surface is just there's too much impedance, right? You really can't do it. So that's the nice thing about MEG is that it's not attenuated by the amniotic fluid and all the other tissue. It's really the only way you could do an EEG would be actually somehow to get the electrodes on the scalp, and that's just not really entirely feasible. That's a good question. Yes, ma'am.
So, and then that is, the MEG is being used for
Yeah.
research, or do you actually?
For research. Although there's interest in, there are some rare types of epilepsy which tend to start in utero, periodicity-dependent epilepsy, right? Hyperglycemia, non-conductive hyperglycemia. So you theoretically could do clinical MEG, right? You could think about pairing it with, like, let's say you think a patient has a focal cortical dysplasia on their fetal MRI. You could theoretically look to see if there's any abnormal source localization to corroborate that. You could. I don't think we're doing that anywhere near routinely. But so right now it's a research-basis tool, I would say. All right, last thing I'll talk about, and I think this is the thing that has caused the greatest change, the greatest shift in child neurology, and I think it's caused a sense of disequilibrium in a lot of child neurologists, including myself, and that's genetic testing. Sometimes you feel like you really had become a neurogeneticist in a certain sense, and I'm definitely not a neurogeneticist at all. I say the Odyssey of genetic diagnostic testing. By that I mean both families go through this diagnostic testing odyssey, like what is it, this test is normal, next test is normal. But also the odyssey that got us from karyotype to where we are now, where literally last week there was an active question of should we get a 1-week turnaround whole exome sequence in this patient to help with clinical decision making. That makes me feel just kind of a little vertiginous, right? I mean, that's something I never would have imagined a while ago. Sometimes I think this is actually a little more like the Iliad than the Odyssey, a little more Trojan horse than Calypso, but I'll leave that for you to decide. So karyotype is where we started, right? Karyotype can tell you if there's anything missing, right? Any big things missing, big bands that should be there. It's also actually a pretty good way to detect things like ring chromosomes. That's actually hard to detect other ways, right? So it still has some usage. It was also fun to do in biology class. I did my own karyotype. It was just fine. The next thing that happened was, well, let's do karyotypes, but then let's make sure pieces are there that we think should be there that we can probe for with fluorescence in situ iodization probes, right? So telomeres, right? So telomeres have common sequences. You can look for those with fish. Let's look forward to George because you can make a probe against that sort of thing. So you can make sure that all the chromosomes are there, they look normal, you're not missing any big pieces, and you also don't have one disorder that you're testing for. Right? So that was kind of the next thing. Obviously, you can't say more than that. You can't detect small deletions, and you only can see what you're looking for. Identifies if a piece of chromosome is there or not. Then along comes, and this is not new, obviously, it wasn't new at that time, single gene strategies. So full gene sequencing initially was Sanger sequencing, so exhaustive, kind of laborious sequencing of a gene. It used to be that you'd get a Ph.D. for sequencing a gene. Now you can pay $50 to have somebody do it down the street, literally in 30 minutes, right? You can sequence genes, you can do targeted mutation analysis, probably the best example of that in clinical use, and also an example of how this is challenging is the SCN1A mutation Odyssey. SCN1A has, and this was from a 2015 paper, almost 1,100 mutations that have been published. Right? So basically any mutation that's possible seems to have happened to SCN1A, the sodium voltage-gated sodium channel alpha subunit gene associated with Dravet syndrome and other things, right? So there's lots and lots of mutations, right? You can go looking for the mutations that are known. The problem is that you may not know all the mutations that are potentially pathogenic, right? So if you go looking for them and your test comes back, no mutations found, do you say hooray or do you say, huh? And so often in child neurology we say, huh. Right? What replaced karyotype was largely the comparative genome hybridization or single nucleotide polymorphism arrays, right? Which are basically a way to screen the chromosomes to make sure you're not missing pieces, microdeletions, duplications, copy number variants, which turn out to be a really important component of disease susceptibility. And it's something that's an active area of interest, trying to figure out what copy number variations are associated with risk for disease and so on. It doesn't detect point mutations, though, and you get a sense that each of these have limitations. Karyotypes have big limitations, some utility. These other tests, it's important to remember, don't tell you everything. So your SNP array comes back normal. Again, you don't say hooray. Well, I guess you say hooray. Normal is good, you know, but it's not the end of the story, right? You still don't have an answer. So maybe this would be the answer: whole exome sequencing, right? So you take all the exome, sequence that, right? You can also do whole genome sequence. It's actually more straightforward in a way. You just take everything, put it in. You don't have to extract the exomes, right? You just sequence everything. You end up with approximately 10 billion different sequences that then have to be aligned. But yeah, you can do the whole thing. Or whole exome sequencing, exome is about 1% of the whole genome, right? And it seems to be associated with about 85% of disease variants, or variants associated with disease, right? So it's a good place to start, whole exome sequencing. Comprehensive analysis of all the coding regions. It's using massive parallel sequencing, which is why it can be turned around in a day, 2 days, right? There's a company that's promising to do 17,000 whole exome sequences in a year for less than $1,000 per sequence. That's where we are now. This is part of the whole next generation sequencing, which again is that massively parallel sequencing technology, where instead of sequencing in that Sanger way where you're going through a gene step by step, you're sequencing lots of little pieces of gene and then aligning them with bioinformatics. There are problems with this, though. It's not perfect. I would say the most troublesome aspect is variance, say it with me now, of uncertain significance, right? There's an abnormality that we don't know what it means, and maybe it's fine. And so then you have to test the parents and see if they have it and they're fine, right? And so it's probably not disease-causing, right? There's lots of ways you can think about it and follow it up. But oftentimes we don't know what the results mean. Our tests are smarter than we are. There's also errors. It's not perfect. I mean, a lot of the commercially available ones, their error rate is like 0.1%, but you're talking about lots and lots and lots of base pairs. So that's actually pretty high error rate, right? So you can miss stuff. And incomplete coverage, there are some regions where you have fewer probes, and so your depth of coverage is not as good, and so you can still miss things that way. So there's, as fancy as it is, it's still not perfect. No test is. There's lots of other kinds of gene tests that we do, gene panels. So you've all ordered this, right? The ataxia panel, right, from Athena, right? Because the patient's ataxic. And so you're going to get the ataxia panel that has all the known ataxia-associated genes, because I can't remember them all, right? So gene panels, and there's lots of them, and there's very reasonable, there's a way to use them reasonably, certainly. There's other ways to look for larger sections of DNA that might be missing. And then, of course, there's methylation analysis, which wouldn't really be detected by other technologies. So there's lots and lots of different kinds of tests, depending on what you're asking for. If you're asking about Angelman syndrome, you want to know about methylation. And then I just have to say cell-free DNA, which is another sort of revolution. You can actually detect fetal DNA, naked fetal DNA, cell-free fetal DNA, or cell-free tumor DNA in an adult who has a tumor in the peripheral blood, right? You can detect it because it has polymorphisms that are not found either in the parent or the mother. There's a lot of different ways to do this. Bioinformatics approaches and more kind of classic genetics approaches using different alleles, and you can actually sequence that. And right now, the state of the art, not state of the art, but right now it's used oftentimes to replace, say, chorionic villus sampling or amniocentesis. You can tell whether there's trisomy, for example, that sort of thing, with cell-free DNA. That's being done here probably today, right? Tumor, same thing, so you can sequence tumor DNA without actually having to biopsy. It's just found in the peripheral blood. I think that's pretty cool. And that will continue to be a source for samples that can then be used with these other techniques. All right, so just a quick sketch of where we were, right? So back here, when I was in medical school, we were very excited because it turns out there were some ion channels that were associated with epilepsy. We were all very excited, and we figured that the line would go like this, and pretty soon we would have figured it all out, and we could all just retire. And it turned out that it didn't go that way, right? Because it turns out that most genes that are associated with epilepsy probably aren't ion channels, unfortunately. You can do model-based approaches where you say, well, what should be associated with epilepsy? And that got some more. But it really wasn't until this genome-wide association searches and then now the next generation sequencing era where we've uncovered all of these different genes that are associated with, in this case, these are generalized epilepsies. This was a 2015 review. I just want to remind you that it's only been 62 years since Watson and Crick published their paper about DNA and the structure of DNA. 62 years, right? This is a revolution that's happening very fast. Just a quick list, and we won't talk about these. Genes associated with infantile spasms, thinking back about my patient, right? No diagnosis was found for that guy. What about now? Look at all these genes. None of them are ion channels. Not one of them. None of them are things where I'd say, huh, boy, that sounds reasonable. That makes sense that that's associated with infantile spasms, right? Aristolus regulator, what? Why is that? I don't know, right? But it is. And that's one of the beauty of model-independent searches is that you find things you don't expect. If you search for things you expect, you find what you expect. There's lots of other genes, new ones every week, being associated with different early infantile epileptic encephalopathies. Quickly, the challenges, right? Then we're going to finish up. So you got all these tests. How are you going to approach it? You can start with a karyotype? Probably not. Let's say that you think the patient has Dravet syndrome. Well, you might start looking at a single gene, SCN1A. Look for mutations, look for deletions, duplications. You have to do both. You can't just do one because you can have both. You can miss. You can just do one of those tests. Let's say that you have a patient, though, with an early infantile epileptic encephalopathy, and there's no particular feature that points you to a particular gene, then maybe a gene PEG. Right? If that doesn't show anything, then maybe whole exome sequencing that you can pay for. Right? Having a rational diagnostic approach is important. Informative versus uninformative negative results, I alluded to that already. When you get a negative result, what does that tell you? Well, if you know all the mutations and you look for all the mutations and it says those mutations don't exist, then hooray, you don't have that disease, right? You don't have the abnormal methylation, then you don't have Angelman. Probably, maybe, well, there's some exceptions. Anyway, so a lot of negative results are unfortunately only partly informative or actually uninformative. Variants of undetermined significance, we've already mentioned. That's the bugaboo of explained. It's like you get the MRI that you didn't want to get, and there's this T2 bright spot that you don't think is related to the disease, but now you got to explain to the family that you don't know what it means, and we'll have to repeat it again in 6 months. Right? Same thing with these tests. The technology is getting better. So if you had a SNP done 2 years ago, it's totally different now. So it might be worth repeating. When did you repeat it? It's going to be better next year, too. It's like updating your smartphone, right? Always the risk with genetic testing of unanticipated information. Hey, it turns out he's not your daddy, for example, right? Or maybe more concerned to us, it turns out that you have ApoE4, 2 alleles. So you're at risk for Alzheimer's, and you didn't want to know that, right? But now you do. Bioinformatics is a huge problem, right? We're talking about millions of sequences that have to be aligned. It's about $1,000 to do the sequencing. It's about $10,000 to process the information if you do a rapid turnaround whole exome. Costs about $18,000 because there's a little overhead. Speaking of money, also reimbursement for genetic testing, and that's a problem. If you're going to order it and you're going to get it paid for, you don't want the family stuck with an $18,000 bill or what it might be. And different insurance companies feel differently about reimbursement for genetic testing. So that's an ongoing struggle. The next new thing for this, variants of undetermined significance, there you go. I would love it if they would go away. That may not happen in my lifetime, but I would love to never see them on a report ever again. But the projects that are ongoing to make that happen, the Epigenome Phenome Program, Epi4K, or Heather Mefford, very involved with that, making great progress. So I'm sure we'll get there eventually. All right, so back to our patient, how might things have changed, just to finish. And I'll tell you, just to anticipate your question, would the outcome have changed at this point? Probably not. Probably not. Would our understanding of what the patient has changed? Probably so. Will that help us in the future? Maybe, right? So we're in that awkward in-between teenage phase where we haven't really made enough difference yet in terms of outcome, but we're getting better at understanding things. So fetal MRI, cell-free DNA, cooling, right? And now the patient had their flurry of seizures on CEG while rewarming as opposed to just in the NICU. Is that better? Probably not. Treated with clobazam, which probably helped the atonic seizures more than the other things, right? Diagnosed with the same things, now called something different, but probably understood better. I would argue labels do matter, nosology matters. And the evaluation, so the gene panel was done, didn't show anything yet. Maybe repeat it again in a year when there's more genes available. Really, there are sometimes 100 genes more available when the panel comes out for its second rendition. SNP array, 3T MRI, and then pursuing whole exome sequencing. We'll see if Molina pays for it. And these are my favorite new things. Thing one, thing two, that's Thomas James, our 3-month-old today, and that's Sarah, our beautiful 2-year-old. So, questions, thoughts, comments, anecdotes, deprecations, or anything from me? What would Bruce ask? He'd ask about glia.
Maybe something on video conference.
Oh, good point. My apologies.
So while you're pulling that out, I'll ask, when you had that list of genes that were not channels, but were
Yeah.
still, so are those, I mean, I think I only recognize the red light one, but the rest of them, are they all syndromic?
It's a good question. Some of them are syndromes. Some of them have other, say, dysmorphologic features, other organ system involvement. But a lot of them, there's nothing particular about the phenotype that's different. They have infantile spasms, right? They're not acting like a normal baby, but there's nothing else distinguishing them. It's interesting. Yeah, it's kind of frightening in a way,
Right.
disconcerting.
Right.
That's a good question. Which again is, I guess, a reason why sometimes gene panels are helpful.
Mm-hmm.
You know, obviously, if it's something that looks like ARX, you test for that, no worries. But you know, if it's just infantile spasms, you know, there's maybe nothing else to point you towards a particular gene.
And then how do you evaluate the next variant you get to say, gosh, this looks like a good candidate gene because
Right.
it's
Yeah, exactly.
not channel.
That's exactly right. Yeah, so the variants keep piling up, and then also the gene spot. There's 27 different genes associated with early infantile epileptic encephalopathy now, and that's just one category, right? There's lots of different genes associated with generalized dystonia, right? New ones every week. So, that's a good question. Dr. Carter, sir.
So as opposed to genetic testing, I think this is becoming a bigger and bigger issue, sort of realm of core combinations.
Yeah.
That is the question, are we actually able to test for what we're looking for in the blood? Are we looking for things that are missing? Are we looking for mutations that are present in the brain or other privileged tissues in the body?
Yeah.
Thoughts about what that's likely to be significant
So Dr. Carter has asked an excellent question, which is, oh God, Sid is watching. Hi, Sid. So Dr. Carter's asked an excellent question, which is what about mosaicism, right? So what if this mutation is expressed only in a few tissues, especially privileged tissues, as he wisely said, like the brain? How do you know, right? So maybe your mutation is only present in those mal-rotated or mal-migrated cortical neurons. And the answer is those are things that we can't assess at this point. But say Bill Dobbins is looking at resected epilepsy tissue, right, and looking at that to see if he can detect mutations in that wouldn't be detected, for example, in peripheral blood samples. So it's a difficult thing to assess, obviously, with technology we have at present. Maybe cell-free DNA would work for that too.
But also we're looking at, the tissues that come embryologically from the same type. So if you look at skin or saliva, you're looking at different cells that are coming from, where the DNA is coming from the same embryological those cases. So you can look for mosaicism in those.
So to answer your question, the answer is yes, I believe so. All right, other questions? Thank you very much. Enjoyed it.